Good afternoon. It is 12:11 on Wednesday, March 26th, a beautiful day the Lord has made. Thank you all for all joining us. A packed house here for the Health Subcommittee. Madam Clerk, please open the roll, if you guys don't mind signing in. And then we will take the roll. Madam, well. No pressure, sir. You give.
3.
We'll get assistance down here to the first row there. There we go. Madam Clerk, please take the roll.
Mr. Chairman, you have 8 members present. You have a quorum.
Awesome. Thank you, guys. Any personal orders before us today? Anybody in? I've got a couple myself. Today is Social Work Day on the Hill, so we have a big group of social workers here thanking you for all the work you do. Several from the University of Memphis. If you guys don't mind being recognized as well, if y'all stand up, wherever y'all are at, y'all in here somewhere. There's some. A good deal. And also, if you guys remember on this committee earlier this session, I passed the Make Tennessee Healthy Act resolution, which was great policy, right? And one of the individuals that helped me in scoping that is in the room today, Dr. Ken Berry. He is from Camden. He is a doctor in my community. So thank you, sir, for being here. And we appreciate what all you've done for healthcare in Tennessee as well. So without any further issues before the committee, we will move right along, starting today with House Bill 6865 by Chairman Hicks.
Motion.
Got a motion and a second. And we do have an amendment with, sir. So
Thank you, Mr.
recognized.
Chairman. Yes, amendment 5868.
5868. That is right. Get a motion. Second. All those opposed, or all those in favor say aye. All those opposed, no. Amendment is on. You are properly before us, sir.
Thank you, Mr. Chairman. It is no surprise to anyone that there's a workforce shortage, especially with nurses in this state and throughout the country. Health systems and schools of nursing are trying to find innovative solutions. In East Tennessee, Ballad Health received a $15 million grant in partnering with local TCATs, Northeast State Community College, Walter State Community College, and ETSU to create a pipeline of nurses in our own communities for high school students to show a desire and aptitude for providing care. The program is designed for students who meet all their high school graduation requirements by the summer of their junior year to begin getting hands-on experience and training to be able to enter the workforce upon graduation. Those who have successfully completed the course, have the training, graduated, and passed their licensure exams will be guaranteed an interview for employment in the Ballad Health facility. This bill, as amended, will allow students who meet their graduation requirements before their senior year to begin work toward their LPN before their senior year, creating a career-ready students right out of high school with hands-on experience. As the program is established and continues to grow, the Ballad Health Academy will expand it into our entire service region so we can improve the nursing pipeline to help grow our own in Northeast Tennessee. Thank you.
Question's been called. Madam Clerk, please open the vote. All those in favor of House Bill 865, moving on to Health Full, press aye. All those opposed, press no. All members voted. Any members wish to change their vote? Madam Clerk, please take the vote.
Mr. Chairman, 9 ayes, 0 nays.
Ayes have it. House Bill 865 moves on to Health Full.
Thank you, Chairman. Thank you, Chairman Williams.
Absolutely. Chairman. Next bill will be mine. I will pass it down to Chairman Terry. Do you have the talking points number for him? That thing. I'll talk about for.
All right. Chairman Martin, you are recognized on House Bill 996.
Motion on the bill.
Okay, you have a motion and a second. You are recognized. And do we have an amendment or is this?
Let me get it all together.
I don't think we have yeah, we do have an amendment.
We do, sir. It is 5921.
Okay, need a motion? Yeah, you have a motion second on amendment 5921. If there's no objections, let's go ahead and put that on the bill. All those in favor say aye. Aye. Opposed? Ayes have it. We are on the bill as amended. You are recognized.
Thank you, Chairman and Committee. House Bill 996, as written, would allow certain psychologists to prescribe only drugs that are rational to the practice of mental health. To be eligible, one must have earned a doctorate in psychology and then earned a postdoctorate master's degree in psychopharmacology, pass a rigorous national examination, and then complete 1 year of practice supervised by a medical doctor. No opioids may be prescribed. Prescribing psychologists have compiled a 30-year record of safe and effective practice in 7 other states, as well as the VA military environment. With that, Chairman, I do have several individuals that would like to speak, if you don't mind.
Yes, it looks like it's 4 on the list. Is that what you have? 4? Okay. All right. Without objection, we will go out of session. And see, we have, bring them up one at a time here. Let's have Roger Clark. Do you want them both to come up or? Yeah, okay. And let's have or do you want me to bring them all up?
Yeah, you can probably do them all.
Okay.
That one.
We'll just bring them all up?
Yep.
Okay. I'll tell you what, let's have all 4 of y'all come up. We'll have Roger Clark, Major Jason Anthes, I believe. There's a Katrina Gay and Dr. Michelle Cochran. And let's see here. All righty, thank you. And we'll go, I guess, from my left to right. We'll start here. If you will tell us who you are and who you're with. And this is more than 4. So, yeah. So if your name wasn't called, you weren't on the list. So I've got Roger Clark, Major Jason Anthes, Katrina Gay, and Dr. Michelle Cochran. Who was not called?
I wasn't. I can't speak. I wasn't called.
Okay.
I can't speak. My name wasn't on.
I don't know. Yeah, I've only got 4 signed up to speak. I'm sorry if your name's not on the list. I can't have you. So we'll start left to right. If you can give us your name and.
Good morning. I'm Dr. Jason Anthes.
You're good.
Oh,
You're recognized. Thank you.
All right. Good morning.
And you'll have 3 minutes.
All right. Good morning, representatives. Thank you very much for having me here this morning to be able to speak to you about House Bill 996. I am a board certified psychiatrist. I'm also a child and adolescent psychiatrist. And I work with the DOD, and I have been a career military officer along with a physician. As some of your packets in front of you note, we've had this program where we have prescribing psychologists after the year of training, additional year of training, doctoral level in the DOD for over 30 years. And during my time as a military physician, I've been able to supervise these psychologists, and I've also had opportunities to work alongside of them and see the quality of their work. And so I'm here to speak in favor of this House bill. I've seen it work. I've seen the ability of these trained psychologists to prescribe, but also to diagnose these conditions in a way that allows them to choose or not choose medications when appropriate. I think there's a large disparity. I see this in my practice, and it's often commented nationwide in my profession as a psychiatrist, that getting the correct diagnosis is extremely important if you're going to choose to use a medication or not use a medication. With the prescribing psychologist, their ability to understand the nuances of these medications and of the conditions that would require or not require the use of a psychotropic medication. I think many of us here could agree there is a mental health crisis in our country. I have been additionally trained to work with children and adolescents. I think that we are heading towards rocky territory across our country, in the state of Tennessee, in the state of Kentucky, and even at Fort Campbell, where I spend a lot of my time working. Deprescription is a large reason why I'm here today, because prescriptions are relatively easy to start in many scenarios. Medicine, in my career, it's well nuanced, and it's well known that once a prescription is started, it's often difficult to stop it. And so prescribing psychologists, their rates are 24% less likely to have adverse drug reactions and 20% better outcomes. And so their ability to look at a condition and transfer from a prescription, say if they are referred or they see a patient with a prescription, their ability to say, I have all of these other tools. So psychologists have many therapy tools to help transition individuals, and especially our adolescents.
Sir, if you could just finish up with the sentence, that's be your time. We're going to have question and answer, so you'll be able to finish it. But if you can just give me one closing remark real quick.
I appreciate the opportunity to be here this morning.
All right, thank you. All right. Tell us
Thank
who you are and who you're with.
Right. So Dr. Roger Clark, I also work for the DOD. I'm a psychologist. I'm a prescribing or medical psychologist, and I work in the Child and Family Clinic. And I'm the only full-time prescriber there for psychotropics right now, because there is a huge shortage, as Dr. Anthis mentioned, as you guys are well aware. In fact, in our state, it's about an 85% shortage of psychiatrists needed. That's a nationwide issue. You've heard in testimony in other bills, the huge physician shortage in general across the nation, and that's not going to get any better. It's going to also occur for psychiatry. So this bill has important aspects of care. One is access. Right now, it's hard to get in to see almost any mental health. And if you narrow that down to the niche of prescribing medication, it's even harder. So patients are waiting very long times to get to care. Result is they often see primary care providers, which they're doing their best, right? I mean, they're just trying to hang in there, but they don't have the training to really kind of do that evaluation assessment. They end up usually prescribing something that's kind of in their wheelhouse to do. But unfortunately, this results in then kind of this prescribing cascade, which I know you guys understand as well in this state, with the amount of psychotropics, SSRIs, and things that are prescribed. One of the reasons I went into this is because I was getting patients that were on multiple medications, and I was trying to figure out what diagnosis they were applicable to. So I said, hey, I'd like to be able to help out with that. So what I can do, because I can prescribe, is I can deprescribe. And the data on prescribing psychologists who prescribe is that they deprescribe about 30% of the time. I think you'll be hard pressed to find that data for any other profession that writes. And prescribing the primary care docs, they are just not, they don't have the comfort to often taper people off, and it's the thing they do. So end up, as Major Anthis knows, to get in to see a psychiatrist, often they have to kind of see the primary care doctor and fail 2 or 3 trials of meds. So by that time, they've been to the gamut of multiple prescriptions when maybe they didn't need one to begin with, or they're on 3 or 4 medicines. I get 8, 9-year-olds that are on 4 or 5 medicines coming out of hospitals or just referred from other folks, because we'll start a med and that doesn't work. We'll add another med, that doesn't work, or we have side effects, we add a medication for that. Sometimes that's appropriate, right? We hate to say it, but for some patients, they really need that level of care from a medication standpoint. I'll just say that often I've not found that. And so then I work to try and taper off prudently where I can, try and get to the least amount of treatment of any type that's needed so that person can be healthy and go out and live their life. So this is the thing that was my passion for getting this training. It's, I think, a thing that we can bring to Tennessee and help with access, help with providing a very qualified and balanced care. And as you know from the research that we've provided you, the data is there. The data about us being dangerous.
Thank you. That's 3 minutes.
Yeah.
All right.
Hi. I want to thank you for this opportunity.
Give us your name.
Yep,
And who you
I'm
work
Dr.
with.
Michelle Cochran. I am a board certified psychiatrist here in Nashville, Tennessee. I want to thank you for your leadership and your willingness and participation to try to tackle the mental health needs that we have in our state. I am currently the chief medical officer at a practice that is physician-owned, psychiatrist, that is insurance-based, that has availability of appointments within 1 week in Middle Tennessee and in Memphis in about a month. Our practice works in a team-based model with physicians, psychiatrists, nurse practitioners, and therapists. We have tried to recruit psychologists in our state. They do not wish to be in the Middle Tennessee in-network. I'm currently the Tennessee Psychiatric Association president, and today I represent myself and the Tennessee Psychiatric Association, the Collaborative Care Coalition, which is the Tennessee Medical Association, the rural and family physicians, the OBGYNs, the pediatricians, the surgeons, ophthalmologists, orthopedists, anesthesiologists, radiologists, dermatologists, and other societies in our state. We collectively oppose this bill, and I'd like to explain why. While this is well-intentioned, this bill puts Tennesseans at risk. The program that you just heard about is a DoD program that cost on average about $600,000 per psychologist that went through that training. Psychologists in our state and in many other states, most other states, are not medical doctors. They have not been medically trained like other mental health clinicians that receive medical training for prescribing. That would include psychiatrists, psychiatric nurse practitioners, and psychiatric physician assistants. We believe this bill is dangerous. We fear it's going to lead to overprescribing for children, adolescents, and adults. And I and the organization I represent all wish to help with to address the problem that we have in our state. We believe there's other options to expand the workforce. There are collaborative care models like the one the TPA put forward this year and looks as though it will become a law. There are loans and grants and IMG processes that we can put in place in this state and that are advancing this session. We could get better reimbursement from TennCare that would allow more doctors to be in network. And currently, if any psychologist in our state would like to become a prescriber, it takes 2 years to become a psychiatric mental health nurse practitioner, and that is a much better, safer program than what is currently proposed. I thank you. I appreciate this opportunity to speak, and if you have any questions, I would love to answer them.
All right, thank you. And go ahead and tell us who you are and who you're with. You'll have 3 minutes.
I'm Katrina Gay, and I'm here today on behalf of the National Alliance on Mental Illness of Tennessee, NAMI Tennessee. We are an organization of families and individuals with lived experience of mental health conditions, and we respectfully voice our opposition to this bill. This bill, which proposes to expand prescribing privileges for individuals who lack the necessary medical training, poses serious concerns for the quality and safety of mental health care in our state. Mental health conditions are complex medical issues that require expert evaluation, diagnosis, and ongoing care from qualified medical professionals, not only to ensure effective treatment, but also to safeguard the well-being of those that are affected. Decades ago, when I began my journey as an advocate, as a mother of a child with mental health condition, many people assumed that mental illnesses were solely the result of poor parenting or environmental factors alone. Through the years of advocacy and scientific advancement, we now know that mental health conditions are influenced by a combination of biological, genetic, and environmental factors. This understanding underscores the fact that mental illnesses are medical conditions requiring medical treatment by properly trained professionals, with the best outcomes being achieved through a combination, really, of appropriate medical care, therapy, and community-based supports. This state does a really good job in this legislative body of supporting and funding an ongoing mental health care system. Here today, I have more than 50 people from NAMI, Tennessee, many in this room who've left their families and their jobs to travel from across the state to talk to you and share their stories with you. I urge you to carefully weigh as they meet with you today, those of you who haven't already, to listen to their experiences. They have stories to tell that will really help inform what that real experience has been like on the back end, not from a medical professional, which is a great voice to hear, but by the patient and the family and the individual. On behalf of NAMI Tennessee, we respectfully ask that you vote no on House Bill 996. Thank you for your time.
All right, thank you. And I think we have a few members that may want to speak. Chairman Williams.
Thank you. Thank you all. Thank you, Chairman. Thank you all for your testimony here today. A question for you, Doctor, is do you look at for instance, do you think that every medical professional that's currently prescribing medications to our youth in the state are qualified to prescribe prescriptions that would assist them in their mental health capacity? For instance, a pediatrician, I take my child to the pediatrician, and are you fully, do you fully believe that a pediatrician has the ability to understand the long-term consequences of prescribing a child one of these pharmacological agents that they may never be able to get away from their entire life?
You're recognized.
That's a loaded question.
It is.
So are you talking about a
It's because I've heard
specific
many
medicine?
stories that Dr.
Are you
Gray,
talking about a specific medicine? Are we talking Prozac? Are we talking Adderall? What
Adderall.
specifically?
I have citizens that come to see me. They're a little bit concerned. They go to the pediatrician. My kid's acting out. He's misbehaving, of which I was one. Didn't spend enough time in the creek. Kids don't spend time in the creek now like they used to. And so whenever I was misbehaving, you go find something to do in the yard or the creek. The challenge is I have constituents that are in my district that are 36, 38, still on Adderall. They were prescribed as a teenager for the Adderall. They wish to be off the Adderall, but they cannot do that. The chemical makeup of their brain has dramatically changed from taking it for 20 years. I guess the question is, do you believe a pediatrician fully understands the length, width, and breadth of the challenge associated to a young adult who wishes to be off the Adderall?
You're recognized.
Are you asking me, can the pediatrician take them off? Certainly a pediatrician could take a patient off of Adderall.
I'm concerned more about the patient because I've heard. So what do I tell a patient who says, I wish I could get off the Adderall. I don't think I need it anymore, but I've been taking it for 20 years. I don't think my
I would
pediatrician
Talk to
understood
their physician.
You're effectively not answering the question. Either they do
I'm not
or
sure
they
I
don't
understand the question.
does a pediatrician have the ability to understand the long-term ramifications of prescribing a child Adderall, knowing that the chemical makeup of their brain would change, that they could never not take it again?
Well, I don't know that science shows that to start with, that the brain somehow changes long-term because of the med and then they can't get off of it. If the patient actually has ADHD, there's lots of evidence that they do better with a medicine long-term. There's evidence to show that people have more divorces, that they fail out of school more, that they have job loss, that they have DUIs, that they have other substance abuse if they're not treated. Now, I would presume that one of the things that psychologists in our state and in most states do wonderfully, that I love referring to, is to get neuropsych testing to actually get an accurate diagnosis. Most of the pediatrician colleagues that I know of get testing before they would write a medicine like that. And then they would weigh the risk and the benefit with the parent about whether or not they wanted to treat the patient. There are other treatments besides medicine for ADHD.
Agreed. So do you believe that a pediatrician should have that test prior to, and you'd be okay with?
I generally encourage that. That's what we do in our practice.
I know, but as a legislator, would you suggest that it would be a requirement that that test be given before someone is given one of these narcotics?
You're recognized.
I don't think that the legislators should be deciding what happens medically. I think that a physician and a patient should make decisions like that. So that would be a physician, a patient, and the parent, and they would weigh the risk and the benefits. Sometimes it is so blatantly obvious what the diagnosis is. You get information from a parent, you get information from a teacher, you get other third-party input, And then you don't need testing sometimes because it's a wasteful expense. So what we do know from the literature is that sometimes people who are non-physician trained will make bigger decisions. In fact, there was a paper that came out just a couple weeks ago that showed that sometimes nurse practitioners are writing lots of stimulants and lots of other things, and non-physician trained folks are writing lots of things that they shouldn't be writing. And so sometimes that will take people off medicines. One of the things our practice does is take people off a lot of benzodiazepines because we see them overly prescribed in our state. So
We do. Thank you very much.
you're
Thank you.
welcome.
Chairman Martin, thank you. Our
Yeah, that works.
next on the list.
Thank you, guys. Both of y'all for being here, the sponsor of this bill. I think this is a great dialogue that we need to have in the public and then open to get both sides of an argument. I appreciate both sides. Some of the support that I've heard, though, they've talked about 30 years of studies and things have shown the safeness and effectiveness of what they've done. So have you guys seen any data to the contrary that might counter that component?
So I've seen papers like that. My concern is the two states that have had some of the longest prescribing, that is both New Mexico and Iowa, have higher suicide rates than they had when they started. Now, is that because of? Doubtful, but there is certainly an association with there's more prescribers and yet we have higher rates. So I don't know what's going on there, but that concerns me. And so as a physician, I base my I want to see the research on this. And I don't have good research to show that is somehow reducing suicide rates. It's not improving access. It's not doing some of the things that we want it to do. So.
You recognize?
Any follow up on that component, at least on what you've seen?
And thank you, Dr. Cochran, for talking about the data and the research. I'm a little confused, though, because there's two studies that looked at the two states that are the longest. Actually, one's New Mexico and one's Louisiana. And those studies showed that there was a decline in suicides and self-harmful behaviors. And they used those two states because, as you pointed out, they have the longest history of having prescribing psychologists. Philip Hughes, one of the main researchers of that study, and I can't remember the other group, but both of those showed kind of downward trends. So that's just well-documented data. Access has also been modeled on looking at increasing access with this. And here's the thing. I respect my psychiatry colleagues. I know they're working hard. They're trying to do their best for patients. The nurse practitioners, the PAs, all of them, the primary care docs and pediatricians are trying to do their best, but the system is overwhelmed. This really should be an all hands on deck situation. And I understand the argument. I understand kind of the base for it as well. But there's a number of studies that show this is safe. They've interviewed colleagues of prescribing psychologists. They've all rated the safe practice. The insurance is like 10% more for me versus a non-prescribing psychologist. If we were killing people, the actuariist of those companies would not care about being my friend. They would say, you're too dangerous. The fact is, there is just no data out there. Now, nothing is 100% safe. And I respect safety, and I appreciate the opposition's concern for that for the people of Tennessee. There just isn't that data out there. And again, the idea of the question about the pediatrician, they're trying to do their best. Many pediatricians handle things like ADHD, but where we also get to, and she mentions appreciate it, is the assessment itself, that diagnosis. And this is the thing that is very strongly in our wheelhouse of doing those evaluations, being able to do the neuropsych testing, being able to get that, more well-rounded clinical history of what else might be producing these symptoms that look like, for instance, ADHD, and then if appropriate, treating non-pharmacologically, because that's the thing I feel very confident with. So I'm trained to do both. It's a postdoctoral master's. It's 2 years, just like the nurse practitioner or the PA program's 2 years. That model has been demonstrated to be able to teach the science and the clinical knowledge and skills necessary to prescribe medicine safely. So the data is strong on the efficacy of this. The data is strong on the safety of it. The need is strongly apparent. This is a bill that can help many people. I know there's two sides. I'm just saying, honestly, obviously, I think a yes is the right thing to do for the people of this state.
Thank you, guys, both of y'all.
All right, anybody else on the list that they can collect out there? While you're still here, thank you guys all for coming here. I do want to point out something a couple of y'all have said, and it goes back to, you mentioned something, all hands on deck, but trying to improve that. And we do have a physician shortage here. I do want to point out, I guess last week they had the match for residencies, and Tennessee, we have 37 slots and they filled all of them. So we filled 100% of our slots here. But in a lot of our specialties, we have filled 100% of the slots, but the problem is we need more slots, and that's some issues that we're having to deal with at the federal level. So, but thank you for your comments, and with that, we will go back into session. Chairman Martin, you are recognized.
Thank you, Chairman. Again, thank those guys for coming. I think this is a great conversation and dialogue that we needed to have. As on the healthcare side of it, I see every patient-centric approach is what we need to continue to look at here in Nashville. And I think we saw two sides of an argument that is patient-centric if we can get there.
Chairman Williams, you're recognized.
Thank you. Obviously, I'm very. I've met with a lot of people regarding the subject matter. I probably am one along the lines that wants to see more data surrounding it. If someone has a mother who just recently lost their loved one and they go to a general practitioner just to get a checkup and they leave with an antidepressant because they're mourning the loss of a loved one, they may or may not need that antidepressant. They may need time to mourn. And so there's so much going on as it relates to this subject matter. I feel like it's this committee and this legislature's responsibility to make sure that we provide the best care and the platform or the ability for the best care for all of our citizens while recognizing the science and the individual patient's needs. And so, Chairman, with your permission, I think it's very important that we continue to study this subject. I don't think it's something that obviously has been fully formulated at this point. I think it's something that we need to continue to discuss, and it's my hope that we do that. And with that being said, I would make a motion to actually have this studied over the summer, that this body, this committee, this chairman, and the people that testified here today, their input would be taken into consideration as we study to see what that is. So my motion would be for summer study.
Okay. We will need a second on that.
Second.
Okay. That's non-debatable. What?
You can recognize.
I can recognize. Okay.
Yeah, no, I
you're
greatly
recognized.
appreciate that. I think that is the most educated and best step for Tennesseans. We're here to work on patient-centric approach, and this will bring everybody to the table to have a collaborative conversation with the research, with the data, come back here in January and make sure we get it right. So I am all in favor of that. I appreciate all you guys having great dialogue and conversation on this.
Okay. Can I recognize? Okay. Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. And yeah, I appreciate that. I just, I hope we're serious about this. I would like to be a part of this, and because the need is there, and we need to do this. I really don't. I'm looking out for the best interest of the patients and looking to get the best care for the patients. And, I'm really not interested in, a turf war between professions. I'm more interested in doing what's best for the patients.
All right. Thank you. All right. Without objection, we will be voting on summer study. All those in favor say aye. Aye. Opposed? Ayes have it. House Bill 996 moves on to, let's put it on the board. All those in favor of House Bill 996 moving to summer study, vote aye. All those opposed, vote no.
Yes.
All right. Clerk, please take the vote.
Mr. Chairman, there was 9 ayes,
All right.
0 nays.
All right. Thank you. House Bill 996 moves on to summer study.
Committee and chair. All right, this brings us back to our calendar. Item number 3, House Bill 1141 by Chairman Boyd. You are recognized. We have an amendment with this, I believe.
Yes, Mr. Chairman, I've got amendment drafting code 6415.
Motion second. All those in favor say aye. Aye, opposed. Ayes have it. You are properly before us,
Thank you,
sir.
Mr. Chairman. It is great to be before this committee and 3 of my teammates from last night. And I got to tell you, Representative 3-Point Mitchell, if there's no pressure, man, it's nothing but net every time. And it's great to see y'all today. So this bill is a terrific bill. This is brought to me from the Tennessee Healthcare Association. And so this bill deals with the Health Facilities Commission, and there have been some problems with the Health Facilities Commission with the recertification surveys, getting them done within 15 months, which they're required to do by CMS. And so this would put into statute starting January the 1st of 2027 that they would have to meet that 15-month deadline. It also instructs the Health Facilities Commission to start working with CMS to work toward a block grant waiver. This would be the first of a kind in the country. And so it would instruct them to start that process. And then it would also put some reporting requirements on the progress of the block grant waiver that we would have to report back. And then it also names 3 assisted living industry groups that can provide the governor with a list of qualified candidates to fill the assisted living positions on the commission. Those 3 are the Tennessee Center for Assisted Living, Leading Aids, and Argentum. And Mr. Chairman, I could very simply tell y'all more about that block grant waiver. It's so easy, but if you do need to hear from someone, I do have Logan Grant from the Health Facilities Commission. I also have Chris Peary, who's outside counsel for the Tennessee Healthcare Association, if the committee would like to hear from anyone.
I'm not seeing any. Any questions for the sponsor? Not seeing any. Madam Clerk, please open the vote. All those in favor of House Bill 1141, moving on to Health Full, press aye. All those opposed, no. Have all members voted? Any members wish to change their vote? Madam Clerk, please take the roll or vote.
Mr. Chairman, 8 ayes, 0 nays.
The ayes have it. House Bill 1141 moves on to Health Full. Congratulations.
Thank you, Mr. Chairman and committee.
Item number 4, HJR 122, has been taken off notice. That brings us up to item number 5, House Bill 638 by Chair Lady Carringer. Get a motion and a second. All right, and you do have an amendment before us?
I do, Chairman. It is 006091.
That is what I've got. Let's add that on there. All those in favor of the amendment, vote aye. Opposed, no.
Doesn't she need to put the other one?
3 different ones.
Does 006091 work without the 0? Okay. I thought she was okay. Sorry.
So very good.
Can you get clarity that she?
Can you get clarity that the one you want is 6091? Is that correct?
Yes, Chairman. Yes.
Perfect. Just that one.
Yeah, I mean, Senator Watson may have added or may add something, but I mean,
That's
right
the
now,
one
that's what
before
I've
us.
got.
Okay.
Yes.
That is the one before us then. So we got a motion. Second. All those in favor say aye. Aye. Opposed? Ayes have it. You are now properly before us. Thank you, Chair.
Thank you, Mr. Chairman and committee. So this bill was brought by a constituent. The bill's language and goals are grounded in a similar Texas bill that was passed in September of 2023, which aimed to eliminate healthcare discrimination on the basis of personal choice to immunize. Patients retain the right to refuse immunization on any basis, religious or moral, and their choice to immunize must have no bearing on access to essential medical care. And to that, CHIP, which is Children's Health Insurance Program, does not stipulate that immunization is a requirement, meaning that restriction of medical access would compromise people's access to medical care. This bill would enshrine respect for those with differing personal beliefs and protect low-income families from being forced into undertaking certain medical action that is contrary to their beliefs. So what this bill promulgates is that refusal to treat a patient based solely on immunization status is prohibited. Any infraction would necessarily incur the penalty of no reimbursement for a health provider who is taking TennCare patients or Cover Kids insurance. So with that, I will stand here
Thank
for
you,
some
Madam
questions.
Chair. Do we have questions before? Representative McKenzie, you're recognized.
Thank you, Mr. Chair. So this bill, sponsor, if a person had tuberculosis or was not incubated for or had a vaccine for tuberculosis, you're saying that a doctor or a outfit would lose their license. Well, they would lose their ability to be paid by TennCare if they said this person needs to have service, or we know a doctor over here that will take you. But if they refuse and say, but we've got these 5 alternatives, because these are clinics or offices that believe like you believe, and this to the patient, you're saying that they would lose their ability to receive additional TennCare payments.
Madam Chair, you're recognized.
Thank you, Representative, for your question. The amendment that we just put on does not apply to a provider who is a specialist in oncology, organ transplant services, or a physician who is treating patients who are immunocompromised, including patients who are immunocompromised because of a disease or as a result of treatment for disease. So TennCare has all kinds of requirements, and any physician that accepts this would simply be a TennCare requirement. So any physician that accepts TennCare patients or children, they have the rules to follow. And so we're simply saying that you cannot deny seeing a patient based solely on their immunization. But we also have all of these covered, which I think should answer your question.
Representative, you're recognized.
Thank you, Mr. Chair. So yeah, it did. It said that if you're going to a pediatrician's office because your child is sick, maybe with tuberculosis, but they're not a cancer patient. They're not looking for a transplant. They don't have anything that they know, or this isn't a center for the immunocompromised, that they're going to now be refused. If they have 1,000 TennCare patients, all those patients now go away because all I'm trying to do is keep tuberculosis out of my office and make sure that we're doing that here. But I'm giving you alternatives. We just spent a lot of time on yesterday speaking on a bill that allowed doctors to make decisions. Now, I was against that bill, but that bill cuts both ways. This bill is in stark contrast to that bill. This bill says if I want to keep on getting a check for the services I'm rendering to my patients, and these patients that I know and love and been treating for 10, 15 years, I'm going to give all that away because I have a conviction that says I don't want to have, and I'm picking on tuberculosis because everybody focuses on COVID. These bills come about COVID, but there's a lot more than that I'm trying to keep this disease out of my practice by assigning you somewhere else. But you're saying that they're going to lose their ability to recoup TennCare, which might put their practice in jeopardy because of a conscious moral decision that they've made.
Chair Lady, you're recognized.
Thank you, Representative, and thank you, Chairman. Most pediatrician offices that I've ever been in have a well room and a sick room. And physicians all the time can either decide if they're going to accept TennCare, care, or Blue Cross Blue Shield or whatever kind of insurance you've got. So we don't know now when kids come in if they're vaccinated or not. So I don't see, TennCare has a lot of stipulations, and if a physician is willing to take TennCare patients, then they have to follow the TennCare policies. So a physician has the right to refuse, if they don't want to see. But I think most physicians agree to treat all their patients when they come in.
Thank you. Representative Mitchell, you are recognized.
Yeah, thank you, Mr. Chairman. Over the years, this General Assembly has done many great things for the health of Tennesseans. 1966, the General Assembly passed a law requiring children entering kindergarten to have certain immunizations. 1978, Tennessee General Assembly unanimously, Democrat and Republican alike, passed a law requiring K through 12 LEA systems to have certain immunizations or they would be penalized for noncompliance. With the resulting being in 1999, measles was eradicated in the United States. TennCare has done many great things, including Tennessee once led the nation in childhood immunizations for several years in a row because TennCare required, if you were to be on TennCare, you would have your child with the childhood immunizations that were required. So we ranked number one in the nation. We were doing what we were supposed to do as a body to keep Tennesseans safe and healthy. Well, within the last few years, our failure, because it's our failure as a General Assembly, we have went from first in the nation as of late of 2012. We were the number one state in the nation in childhood immunizations to now we're 35th in the nation. We should ask ourselves, what are we doing? Are we doing what we should be doing to protect all Tennesseans, not just a few who don't like, some requirements, but sometimes you have to protect the many over the few. And if we keep going down this line, ladies and gentlemen, we're doing a disservice to the people we represent. We may be making a few of our constituents happy who don't like certain requirements, but in the end, we are harming all Tennesseans. We're putting all Tennesseans at risk. And to continue going down this path just because, we had a once in 100-year pandemic, and thank God everyone in this room survived it. We're doing things that next time not everyone will survive it. So with that being said, I surely hope we don't continue down this path because this is not for the best of all Tennesseans.
Thank you, Representative. Chair Lady, any follow-up?
Thank you, Representative, for your statements. And vaccines do save lives, and I support vaccines. But again, it is totally left up to the parents, particularly with their children, and it is a choice. And so, we already have where you can refuse any kind of immunization because of your morals and religion. So this is just saying if you want to take TennCare and children, and the parent doesn't believe that their child should be vaccinated, that's their role. And so a physician shouldn't be able to just refuse to not treat
Thanks,
you.
Shirley. Representative Mitchell, one more follow-up.
Yeah, I'll just give you one last tidbit. The state that is now number one in childhood immunizations is the state of Massachusetts. They were also the state in 1905 made it a crime not to take the smallpox vaccination, and they fined people who didn't take the smallpox vaccination, and that went all the way to the United States Supreme Court, and that is still good law. and they are number one in childhood vaccinations now. And obviously, for a reason, they're doing what's necessary to keep all their citizens safe and healthy.
Thank you, Representative. Chairman Hill, you're recognized.
Thank you, Mr. Chairman. Move previous question.
Previous question has been called. Madam Clerk, please open the roll. Vote. All those in favor of House Bill 638, vote aye. All those opposed, vote no. Madam Clerk, please take the vote.
Mr. Chairman, 6 ayes, 2 nays, and 1 present not voting.
The ayes have it. House Bill 638 moves on to health full.
Thank you, Chairman and Committee.
House Bill 644 is off notice. Moves us to item number 7, House Bill 1349. Madam Chair Littleton, you are recognized. I believe you have an amendment as well.
I do. It's 6069.
Let's get that on there. All in favor say, or motion? And second, all those in favor say aye. Aye. Opposed? The ayes have it. Madam Chair, you are recognized.
Thank you, Mr. Chairman. This bill, as amended, requires a county medical examiner's office or regional forensic center when conducting an autopsy on a descendant who is suspected to have committed a mass murder or mass shooting that resulted in the deaths of 4 or more individuals, to consult such decedents, treating mental health professionals or primary care physicians, if known, to obtain the information regarding the descendant's psychotropic drug use, and requires the county medical examiner to test the descendants for the presence of any drugs, including psychotropic drugs. Requires the county medical examiner's office to require or regional forensic center to disclose the drug use to the descendant of the University of Tennessee's Health Science Center, College of Pharmacy, and the Department of Health, and establish that the county medical examiner shall send only a blood sample of the decedents to the HSC, and requires the HSC to study the drug interactions between the psychotropic drugs and any other drugs that were present in the decedent's system. And it requires the HSC to submit a quarterly report of the data obtained pursuant to the legislation to the chief clerks of the Senate and the House of Representatives. And there is no mandatory reporting if there is nothing to report.
Thank you, Chair Lady. Any questions before us? Representative Mitchell, or Representative McKenzie, you're recognized.
Thank you, Mr. Chair. And we may have to go out of session for this one, but the sponsor may know that. I know for a fact that for some strange reason, mass shootings are 4 or more that aren't considered a gang-related shooting. For some reason, those are pulled out. So does your bill, hopefully legals is listening, that they may need to chime in, does your bill include a gang-related shooting that has 4 or more people that were killed in that offense?
Madam Chair, do you know that?
I'm not educated on the game, so no, we'll have to ask legal, please.
Without objection, we'll go out of session.
You want me to ask it again?
I got it. Heather Asbell, Legal Services. The bill just says committed mass shooting that results in the deaths of 4 or more individuals. So it doesn't specify gang related, and it doesn't exclude it either. It just says 4 or more deaths of an individual. Does that answer your question?
Representative.
Thank you. Kind of, but kind of not, because and we dealt with this after the Covenant shooting issue, was mass shooting has a definition in law. And in law, that definition of mass shooter excluded these types of crimes. So when I saw mass shooting, then I saw 4 more. Just want to make sure, because I would like for them all to be, but I think the word mass shooting limits the folks that are going to get this type of blood drawn and entered into the database.
Representative McKenzie, the mass shooting is not defined in Section 38.7.109 that this bill is amending. And so that would necessarily apply. That'd be up for a court to decide, but it's not defined other than what's in the bill, which says committed mass shooting that result in the deaths of 4 or more individuals.
Thank you.
Without further question, we'll go back in session. Any further questions for Madam Chair? Not seeing any. Madam Clerk, please open the vote. All those in favor of House Bill 1349, press aye. All those opposed, no. All members voted. Any members wish to change their vote? Madam Clerk, please take the vote.
Mr. Chairman, 9 ayes, 0 nays.
The ayes have it. House Bill 1349 moves on to health full. Brings us to item number 8, House Bill 1351, also by Chair Lady Littleton. Get a motion. Second. And you do have an amendment before us.
6498.
That is what I have. Get a motion. Second. All those in favor of adding on an amendment, say aye. Aye. Opposed? No. The ayes have it. Chair Lady, you're properly before us.
Thank you, Mr. Chairman. First, I want to say that I have worked with mental health. I have worked with recovery centers. I think I've spent more time on this bill than my whole 13 years here on any other bill, maybe all of them put together. So with that being said, everyone seems to be in agreement with this. That would make it ADA passable as well. So it requires a nationally recognized recovery resident standards organization performing certifications of recovery residents in the state to adopt certain minimum standards as part of certification, and requires the Commissioner of Mental Health and Substance Abuse Services to select and approve organizations meeting to establish minimum standards.
Thank you, Chair Lady. Chairman Terry, you're recognized.
Thank you. And you mentioned it, but I was going to mention for everybody else to know, you've worked very hard on this piece of legislation, worked with all the individuals to get this bill in a good place. And I really do. I mean, late nights at times I was in the room. So the work that you have done, I appreciate that. So thank you.
I can second that as well. Thank you, Madam Chair. Any further? Yeah, Representative or Chairman Hicks, you're recognized.
Thank you, Mr. Chairman, and I want to third that. You have done a great job. This is a complicated issue, and it's something that our good centers or good recovery homes, we don't want to hurt them. So that's what makes this so hard. So we appreciate your work on it. And you know what? In the years to come, we'll do more on this issue and work it out. So thank you very much for your hard work.
Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chair. And Chair Lady, I just had a group yesterday, and I don't want to single out any one group, but they came to my office yesterday and still concerned about the ADA compliance. So you're confident now with your amendment that we've overcome those obstacles? And
Madam Chair,
trust me, I'm overconfident because this is not near what I wanted to do. But Dixon, my county where I live, we're kind of like, we have a lot of the recovery homes, and so we're just trying to make sure that everybody's a good neighbor, the recovery homes plus the neighborhood themselves, so that they feel more comfortable with what we're doing. Because when you have a numerous amount of them, then kind of weigh a lot of them. I'm just going to leave it at that. We just want them all to be good neighbors, including the recovery centers as well as the neighborhoods.
Representative Mitchell.
Thank you, Chair. I believe you. Then I'm good. I just don't want us to do anything that would, harm anyone's ability to get fair housing.
Madam Chair.
I have Commissioner Williams on speed dial. We have talked numerous times, and I've worked with her diligently to make sure that we are.
Representative or Chairman Williams, you recognized.
Thank you. And I want to say thank you too. I think in my district alone, there were none of these 5 years ago. Now we have 62 in the city of Cookeville. I think there's 13 in up the Baxter area and several in Allgood as well. We do want to make sure people are getting the treatment that they need, and it's qualified treatment, so that when these resources are spent at the federal and state level, that they're getting the help that they need. And it's just not a place for someone to acquire resources to put someone in a home. If one of these homes pops up beside your home, chances are the value of your property is diminished, and local planning, zoning, and codes don't apply because of the way the Fed has changed the definition of disability as it relates to substance abuse. So it's a very difficult situation. And as someone who has constituents where they lost a neighbor, and then they have a new neighbor, but it's not a family, it's a group of 8 people in a home. It makes them and their family extremely nervous, knowing that there's no oversight or guidance at all as it relates to ensuring those people are getting the help and treatment that they so desperately need, with some oversight by someone living in the home to help them just do the daily work that we and others do. So I appreciate this. Hopefully we'll be able to shine a light on just how big this number is across our state. And I think we're all going to be shocked when we get the results. Thank you.
Madam Chair.
You said that so much better than I did, so thank you. But it is a problem in every community, and Dixon seems to be one of the larger ones right now, but I see the surrounding counties growing as well. And they do have, the ADA rights, and so we have to be careful what we do. But we want everyone to be a good neighbor, including those houses, but we have to teach the neighborhood as well that we all have to be good neighbors.
Rep. Chairman Hicks, you recognize?
Chairman, I'm sorry, just one more time. On the other side of that, I have personally witnessed, an entire group of men that live together that become family. And I mean, their complete lives change. They take care of one another. They've got each other's backs. They're going through recovery. They're going through recovery together. And I'm telling you, this thing, if it works right, it works very, very well. There's folks that work for me that goes home to these every single night, and they go to work together, they pray together, they eat together, they do everything together. They become family. So this, after someone has went through a recovery process, and instead of going back into bad situations, this is exactly what they need. So these things are also very, very good for these people. So I'm one of them, and proud to be. And there's nothing better than getting back on track and using this process. Thank you, Chairman.
Thank you, Madam Chair.
Just one last thing, but yes, some of the recovery houses, they help the neighbors next door if they're moving stuff in, or help them move things around, help them work in their yard. But then there are others that don't. But again, we just want everybody to be able to get along and be in the same neighborhood, because we're all here.
Absolutely. Without further question, Madam Clerk, please open the vote. All those in favor of House Bill 1351, press aye. All those opposed, no. All members voted. Any members wish to change their vote? Not seeing any. Madam Chair, Madam Clerk, please take the vote.
Mr. Chairman, 9 ayes, 0 nays.
The ayes have it. House Bill 1351 moves on to health full.
Thank you, Mr. Chairman and committee. I think our hard work has paid off. Thank you.
That's it. Moving on to House Bill 960. And a motion and second. Representative Love, you do have an amendment, I do believe.
Yes, sir, Mr. Chairman. It should be, is that 004786?
That is what I have.
All right.
Put that on there first. A motion second. All those in favor say aye. Aye. Opposed? No. Ayes have it. You are properly before us, sir.
Thank you, Mr. Chairman and committee members. House Bill 960 seeks to provide opportunities for continuing education for medical professionals, particularly in the area of maternal mental health. And it simply does that, Mr. Chairman. I can read the amendment if members want me to go into detail about it. Thank you.
I'm not seeing any. Any questions for the representative before us? Not seeing any of them as either. So, Madam Clerk, please open the vote. All those in favor of House Bill 960, vote aye. All those no. All members voted. Any members wish to change their vote? Not seeing. Madam Clerk, please take the vote.
Mr. Chairman, 9 ayes, 0 nays.
The ayes have it. House Bill 960 moves on to health full.
Thank you, Mr. Chairman and committee members.
And item number 10, House Bill 992, Representative Love has been taken off in the Senate.
Off
So we
notice.
will
Unless y'all want me to.
You're,
Okay, all right.
you can hang out all day if you'd like, but that,
Thank you, Mr.
your
Chairman.
job is done. Thank you, sir. Off notice. That brings us up to item number 11. House Bill 1049 is off notice. Item number 12, right on time. There we go. Representative Chairman Garrett, we get a motion. Second. Any amendment with this bill? Not seeing any.
I don't think we have an amendment. We're ready to roll. If you
All
are, Mr.
right,
Chairman.
Chairman, you are properly recognized.
Thank you, Mr. Chairman. Committee, CON, Certificate of Need. What does that mean, right? We're here today. When I talk to my folks back home, those that, you know, I'm blessed. I think we're blessed in many ways, Mr. Chairman. I live near a city where there's multiple hospitals to choose from. If there's something wrong with me, I can usually find someone that can take care of my ailment, right? That's not always the case across the state of Tennessee. And so I know that there's been a lot of discussion, a lot of definitions, a lot of talk about certificate of need and what that looks like. When I talk back home about folks to understand what that is, they just don't. They don't understand what that is. So I know there's several folks, I believe, Mr. Chairman, signed up. I do have some comments to make. I think it'd probably be better if the committee heard from them.
Absolutely.
And then I can come in on the back end of that if that's okay with the committee, but I'm willing to do
Without
whatever.
objection, I think that is good. We'll go out of session. And we do have, we do have two on each side, I do believe, of the argument. Miss Lacey Blair, Miss Frida Russell, Miss Charlotte Burns, and Miss Colleen Lindergren. If you guys don't mind coming on up and, have a seat there. And what we'll do is start, y'all are seated? Yeah. Each side, good. If you don't mind, as we mentioned previously, mind stating your name for the record, and then you'll each have up to 2 minutes as needed. We'll start. Lacey was first, so we'll start with Lacey. She's already seated. Good to go. You're good.
Good afternoon, Chairman and Committee. Lacey Blair with the Tennessee Hospital Association. With me today is Frida Russell. Frida is the Chief Administrative Officer for Ascension St. Thomas, Three Rivers, and Waverly. THA is here today opposed to House Bill 819. Last year, THA came and worked with the General Assembly to pass significant reforms. That was last year again in 2024. And those significant reforms were taken in a thoughtful approach starting in December 1, 2025 with moving 4 services. Those thoughtful approaches continue through 2029. Part of the General Assembly's wisdom in making those significant reforms last year was to actually remove certificate of need prohibitions and the part of it in counties without a hospital, acute care licensed hospital. That's 22 counties. If this bill were to pass in its form and add acute care to out of the CON current process into a licensure process, no one is going to look to those 22 counties. Hospitals and health systems are encouraged by the removal of those 22 counties to look there now to see if it would make sense. If you were to go ahead and remove acute care, these health systems are simply going to wait out the time clock, buy up property, and wait until 2028. They're going to go to urban and suburban areas. Again, I have Miss Frida Russell with me. She does run a rural hospital, and she can speak significantly to how her hospital could be impacted because they do rely on a larger health system to support their mission of caring for their more rural community.
Thank you, Miss Lacey. Miss Frida, you're recognized.
Good afternoon, Chairman Martin and members of the House Health Subcommittee. As Lacey said, my name is Frida Russell. I appreciate the opportunity to speak before you today on behalf of hospitals across the state of Tennessee, particularly those in rural areas, regarding the removal of acute care hospitals from their certificate of need process as proposed in House Bill 819. THA strongly opposes this bill because it threatens the stability of rural hospitals, which are already under financial pressure. Rural hospitals play a critical role in providing essential access to care close to home for some of our most vulnerable populations. The current CON framework, agreed to last session, supports access to quality care for Tennesseans in their own communities where they live, work, and raise their families. Rural hospitals are typically smaller and face unique challenges compared to their urban counterparts, including fewer resources, limited access to specialized health care providers, and lower patient volumes. Because of these challenges, rural hospitals often rely on resources and affiliations with larger systems to provide services which might otherwise be unsustainable on their own. Services at rural hospitals are carefully tailored for the community, balancing access, special support, and inpatient beds. The protections enacted last year for existing rural providers ensure that this careful mix of services remain in communities, while mitigating the risk of increased costs to patients in those communities. Last year's changes to the certificate of need process were especially focused on rural access. One of the changes exempted from the CON was that new hospitals could be developed in rural communities where there is not an existing hospital. This kind of investment would increase access closer to home while supporting Tennessee's existing rural hospitals. Significant reforms to the CON process passed in 2024 as a thoughtful approach will begin to take effect starting in December of 2025 with staggering implementation times, moving services and facilities to a licensure process through 2029. These reforms were carefully negotiated and include a phased approach to allow for evaluation of their impact over time. Moving forward with additional changes before these reforms have had time to be fully implemented and assessed could create instability and unintended consequences across the broader healthcare ecosystem of Tennessee.
Madam, that's the 2 minutes. Thank you.
Okay.
You got a final line there?
Ask you that a no vote on House Bill 819 protects Tennessee hospitals, rural communities, and the patients who rely on them.
Thank you, ma'am. Miss Charlotte Burns, if you don't mind speaking your name for the record, and you will have up to 2 minutes as well.
Thank you. Good afternoon. I'm Charlotte Burns with HCA Healthcare TriStar Division, and we have 14 hospitals in Tennessee. I'm a registered nurse, a retired rural hospital CEO, and I served on the board for licensing healthcare facility for 10 years and the CON board for 7 years. So my 17 years of service on these boards shaped my interest and engagement in CON. We appreciate the CON reform legislation that was passed in 2016, 21, and 24, but we believe that additional reform is necessary in regard to acute care hospitals. You've heard from THA and others that the elimination of CON for hospitals will put other Tennessee hospitals in jeopardy, especially rural hospitals. They'll threaten access to Tennesseans. I highly respect THA. I served on its board for 15 years. I served as its chair in 2003, but I have to disagree with those statements. They're simply not supported by data. The elimination of CON for acute care hospitals will not result in a proliferation of hospitals. That's been proven out by you eliminating CON requirements for psych hospitals. It will, however, result in needed hospitals being built more timely and without the additional costs associated with CON process. The elimination of the CON requirement will not threaten access to care. It will actually provide quicker access to care by eliminating the process that providers are required to go through to gain approval to build a hospital. The elimination of the CON requirement will not negatively impact rural hospitals. My passion is rural health care. I spent 35 years in my hometown hospital in Savannah, Tennessee, and I would not be supportive of legislation that would impact negatively rural hospitals. Hospital providers are not going to build hospitals in rural communities where there's another rural hospital. Population would not be sufficient to support it. For the same reasons, providers are not building hospitals in distressed counties right now that do not have a hospital, and that can currently be done without a CON. Rural hospitals are not struggling because of CON changes. They're struggling because of reimbursement issues. We applaud the legislature's efforts to transition from CON to a more robust licensure process. Hospitals are currently required to go through robust licensure and survey processes prior to occupancy, and they're expected to adhere to those national standards.
Finishing sentence.
We would appreciate the committee's commitment to move Representative Garrett's bill forward to full House so that we can continue to work on access to rural hospitals or acute care beds in the state. Thank you.
Thank you, madam. Ms. Colleen, you're recognized.
Thank you, Mr. Chair, members of the committee. My name is Colleen Lindgren.
legal policy manager with Pacific Legal Foundation. PLF is a nonprofit public interest law firm that represents individuals in constitutional cases, and we also advocate in capitals around the country. We have litigated over 2,400 cases, many of them in equality under the law, including areas like certificate of need. And we have 18 U.S. Supreme Court wins that have helped advance individual rights across the country. And I would just like to thank you for taking on this critical issue. More than 4 decades ago, the federal government incentivized certificate of need laws, or CON laws as they're often known, in states. And this was under a misguided attempt to ensure that higher quality of care by restricting growth, which doesn't really make sense. And the federal government quickly reversed course, and every presidential administration since Reagan has recommended states eliminate certificate of need laws. And yet some states continue to subject themselves to what has just become a very unproductive method of regulation. Con laws operate under the guise of allegedly furthering public health access, but the data clearly demonstrates the opposite. 40 years of research have shown that con laws fail to provide an adequate supply of healthcare resources and are associated with greater racial disparities in access to care, increases in healthcare costs, and decreases in the quality of healthcare. It also stifles innovation for care providers across the spectrum. In fact, nearly every study done looking at supply and access to care finds that there are fewer service providers and services offered in states with certificate of need than in states that don't have it. Moreover, a 2024 study summarized 85 peer-reviewed analyses on the effect of con laws across diverse medical fields and found that the average patient in a con state has access to 30% fewer hospitals, 14% fewer ambulatory surgery centers. The same exists for rural areas as well. In those states, 25% fewer open heart surgery programs, 45% fewer facilities for coronary artery bypass and similar specialties. And patients in con states also have access to fewer imaging devices and hospital beds. So at a time when healthcare costs are rising, we encourage your support of this bill and ask for a good vote.
Thank you, madam. Any questions for yes, Chairman Williams?
Thank you. I guess I should call you Nurse Burns, but thank you for coming today. I do have a question. Obviously, as THA has mentioned, I unfortunately played a role in what was going on with last year's reforms and the phasing out of the vast majority of CON, which I think we're all in agreement is a good thing. I think you would think that is a good thing too. I guess the interesting part, obviously you being from Savannah, I'm from Cookeville. It's kind of an interesting scenario providing rural healthcare, particularly in Putnam County. There are 8 counties really that call Cookeville Regional Medical Center home. One of the things that I did like about the reforms that we had with CON last year was the discussion around the idea of payer mix. It was kind of an opportunity for us to really level the playing field without it being as overburdensome as you described CON. I think most people agree, even attorneys from out of town. But the question I had for you is, if instead of an outright removal in this one sector, what's your thoughts about a payer mix requirement for this, similarly to what we did in the phase in of the other? If you have an opinion about that, since you've kind of been on every side of the situation.
And are you mainly talking about like percent of 10 care, percent of Medicare?
So as you well aware from Savannah, I don't know what their hospital is, but in mine, I think I have 5 different medical groups that have participating agreements in different things from heart to obstetrics to ER, different not ER, but surgery. And so it's a completely different thing because we have, as a hospital, we have all these agreements out there. And right now, if you want those services in that region, you've got to come to this hospital. And payer mix, what it said is, let's do this, but 61% of the population mine is public insurance, TennCare, Medicaid, and in that instance, it would be easy for someone to come in and say, hey, we're going to compete against you, which I'm all for competition. I do think it improves overall healthcare, but on the other hand, is if your reimbursement rates are as big as they are as big hospitals, because mine are much lower. And so I'm trying to compete, and the majority of my payer mix are people who are getting the lowest of the low of the reimbursement rates, those private pay insurers are the ones that really keep us solvent. And so as it relates to this one particular entity that we excluded or didn't opine on in the last revision last year, why not some kind of payer mix for it as well, like we did in the other?
I think hospitals would support that. We all see TennCare, we all see Medicare, and we also have private insurances. So, HCA which is what I'm a part of now, which is the largest healthcare organization.
Right.
We are the largest TennCare provider in the state of Tennessee. So I don't think any hospital would buck on having to have a payer mix requirement.
Right. Particularly for those communities where a hospital already exists. I mean, if you're in an area that doesn't have a hospital or doesn't meet the distance requirements, then there are no distance requirements to be met because nothing exists there. Then a payer mix would be beneficial, in your opinion.
I think it would be fine. I think all patients deserve the right to receive care.
Okay. Thank you very much. I appreciate it.
Thank you, Chairman. Without further question, we'll go back in session. Thank you guys for your presentations. Chairman Garrett, you are recognized.
Thank you. Thank you, committee. I know we're getting rough on time. I put my notes up so I don't talk too much as we can get out of here. But what I want to say is this. Chairman Williams has got some good points. You've got Tennessee Hospital Association who's doing their job. They've got members of their own association that are on each side of this, right? So they got a difficult job to present this. So what I want to commit to you on certificate of need so we can both understand it, so I both can understand my constituents what it means to folks when they need services, when they need medical services, and they've got to come to the government, just like what we witnessed here of two folks, a member of one association that's got to come here to get permission to do something. That's what bothers me about this particular piece of legislation. So what I want to commit to you is if we can pass this out from the sub, I'm going to keep it in full, like I've told most of you about that, so we can have further discussions later on. Come back when we come back here in next January and do this again to see if we can move the ball forward to make sure we have the best system of healthcare in the state of Tennessee. So that's my commitment to you. If you all could vote favorably out of here to get it to the full committee where we can broaden the conversation, I think those conversations are worth it, and I think we can do that next year.
Yep. Thank you. Thank you, Chairman. Chairman Hill. Previous question has been asked. Madam Clerk, well, yep, there we go. Please open the vote.
I think everybody's going to have to log.
You have to log back in, guys. We got.
You'd have to withdraw.
Chairman Hill.
Thank you, Chairman. I apologize. I didn't realize there were questions. I was looking more at the clock. Is it possible to withdraw that motion, or are we ready to go?
It's possible to withdraw that motion.
I'd withdraw that motion and let Chairman Williams and whoever else do what they need to do.
Reconsider that motion then. Yep.
Oh, okay. We'll just vote it down if we have to. What do we do? Can we close it? So it's been withdrawn. We're now.
Yep. Motion was withdrawn, Chairman.
Thank you, Chairman. Thank you, Chairman Hill. I appreciate that very much. I just wanted to ask the leader real quick. I'm assuming, were you able to, I don't know if you were running another committee, were you able to hear my question for Nurse Burns?
Mr.
Chairman, you're recognized.
Was it regarding your payer mix?
Yes.
Yes, I was in the room when you asked that question.
Okay.
Yeah.
So the question I had for you is obviously being somebody who's been here in some people's account too long, the challenge that I have here is if some revision, I'm concerned about moving something to full without some assurances as it relates to payer mix. Is payer mix something that you as a bill sponsor would be open to as it relates to this, similar to what we did in everything else? Because if the bill went forward, obviously it wouldn't come back here for miscegenation as it typically does in subcommittee. So just didn't know what your views on that were.
Chairman, you're recognized.
I think it would be disingenuous for me to ask you and the committee to send this to full without having a full plethora of information that could be part of this piece of legislation without having that discussion.
Mm-hmm.
So I don't think that would be correct for me to say, no, that's not on the table at all. I would think anything at this point to move the conversation forward in a way is on the table. So I would commit that to you, Mr. Chairman.
And I really appreciate that, Leader. What I will say is that because the current language is currently what it is, I think you could move my support if we had a little bit of change as it relates to that. Because under the current language, I'm not for a complete repeal of CON without some kind of structure that we had before. So I'm going to be voting no today, but I will say that I look forward to working with you in full next year, in 2026. It'll be here before you know it. But thank you for that. And thanks again, Chairman Hill, for letting me ask that question. Thank
you, Chairman. Any further questions? Not seeing any. Madam Clerk, please open the vote. All those in favor of House Bill 819, moving on, press aye. All those opposed, no. Nope.
all this pressure.
Yeah.
Stop. 3, 2. Could somebody tell me my password? Thank you, Chairman.
Thank you.
Madam Clerk, please take the vote.
Mr. Chairman, 5 ayes, 1 nay, 3 present not voting.
The ayes have it. House Bill 819 moves on to health full.
Thank you, Mr. Chairman and committee.
Brings us to our final item of the day, House Bill 1396. A motion and second. There is no amendment before us. Representative, you are recognized.
Thank you so much, Mr. Chairman and members of the committee, and thank you for the motion and the second. This legislation is intended to protect against automation and the consequences for people financially. The truth of the matter is I'll be open to any questions. I want to share just a couple of minutes of why I think this legislation is important, but I ultimately will table this because I think there's some more work that I want to do with folks like Mayor Tubbs and the Guaranteed Basic Income community here in Tennessee. But look, poverty is one of the most significant.
Parliamentary question, 1 second.
Chairman, I just as a respect to the member, we're supposed to be in a transition now. I think I just heard the sponsor say that he was not going to run the bill. If he's not, I'd be glad to meet with him and talk to him after the committee. But obviously, we're having a turnover. The chairman's up against the time crunch. This is the last calendar. I don't know. I don't know what we should do here. Thank you.
What's that?
It's a parliamentary
We can roll
inquiry.
it first calendar of next year.
Make that motion.
You make that motion?
No. We're done.
Representative Mitchell.
Yeah, thank you, Mr. Chair. I mean, the gentleman just wants 3 minutes of our time. It's the last bill on the calendar, last thing. Let's just finish our work. Let's give him 3 minutes, or we're going to cause 10 minutes of arguing over not giving the man 3 minutes. Let's just give the man 3 minutes and go from there.
I don't have an issue with that at all. What I'm saying is that we're 5 minutes or 10 minutes past time when we're supposed to be here. There's another committee. I don't know if there's another committee procedurally that the clerk's office does it.
We went over time for that last bill that, not all of us really liked. So let's just give him 3 minutes and go.
Yeah.
Representative.
Thank you, Chairman.
2 minutes and let's get it good.
Thank
You're
you,
good.
Chairman.
Compromise.
Thank you. Poverty is one of the most consequential issues that is facing our communities. And the reality is, as automation continues to have effect on our communities and the corporations that work and operate here in Tennessee, our constituents are going to be significantly and deeply impacted. The reality is we have to ensure that the 10 to 15% of people who are going to be hurt and harmed by automation actually do have a guaranteed basic income. If we do not plan for this, if we do not prepare for this, as is articulated in The Coming Wave by Mustafa Suleiman, we are going to continue to see people in dire need of government resources and money in order to just be able to survive. The need for a guaranteed basic income is to make sure that the citizens who are in our communities, whether they be in urban communities, rural communities, all across the state of Tennessee, have what they need in order to be able to survive, and that we do not continue to proliferate and perpetuate poverty in our state. And so I want to continue to work on this bill, as I mentioned, with other leaders, activists, chair folks as well. But I know that if we do not do something to address poverty in the state of Tennessee, we're going to continue to face the horrible consequences, whether it be in medically, whether it be in education, and definitely socially across our communities. Thank you so much, Mr. Chairman.
Thank you, Representative.
And so with that, I would like to table.
Representative
Thank you for that. Obviously, I didn't, but wanted to make sure that you had an opportunity to hear it. And the question I had for it, does your bill specify anywhere in there of how the department or in the rules would determine harm?
Mhm.
Like it's like or does it say anybody after January 1, 2026? That's when any change that happens because of automation after that, or
Right.
is it just like arbitrary? And if you're unemployed now, but you said, I was harmed by automation, even though I hadn't worked in 6 years, how do you determine that?
Yeah. Thank you so much for that question. Thanks so much for that question. And I think that is going to be something that the Department of Labor more than likely is going to have to work through so that we have a legitimate process to ensure that people who were likely working at some other corporations or working who know that they're no longer going to have a job because of the way that technology is going actually has some compensation so that they don't find themselves in poverty and impoverished because they're no longer able to do that job. In addition, I think there's an opportunity for us as legislators to think about education, skilling, and upskilling for people so that they can continue to participate in this economy.
Agreed. With an unemployment rate like it is and over 100,000 unfilled jobs across the state, it's biblical. If you don't work, you ought not eat. So I think people need to work. If this gets people back in the workplace, that's great. But what we also don't want to do is embolden people to stay at home and collect $3,000 a month, as your bill currently says. So,
and I also think what we have to do as legislators and need to be emboldened is to realize the reality of the situation. A lot of people do want to work, and a lot of people are working actually. And in Memphis, the median income is $32,585, which isn't enough to live off of. I don't think anybody who's a legislator is living off $32,000. And so we need to look at other legislation in addition to make sure that there's a minimum wage increase, in addition to making sure that there's a guaranteed basic income so that we don't have people who are impoverished in our state. Thank you.
Chairman Terry, you're recognized.
Are you, I just want to make sure you got everything that you wanted to say before I make a motion.
I understand that. Thank you, Thank you, Chairman Terry.
Okay, I would move that we roll this to first calendar of next year.
Motion second. All those in favor say aye. Aye. Opposed? None. Roll till the first calendar next year. Thank you,
so
sir.
much.
That concludes our
Closed, subject to the call.
this health committee is closed, subject to the call of the chair.